Good morning, everyone. Now, I think we're able to begin with Professor Leanord.
Indeed, Lord.
Good morning, Professor Leanord. As you know, you're about to be asked questions by Mr. Connell, who's sitting opposite you. But first of all, I understand that you're willing to affirm.
I am.
Sitting where you are, would you repeat these words after me? I solemnly, sincerely, and truly
I solemnly, sincerely, and truly
declare and affirm
declare and affirm
that I will tell the truth,
that I will tell the truth,
the whole truth,
and
nothing but the truth.
nothing but the truth.
Thank you, Professor. Now, your evidence is scheduled, I think, to go over the whole day. We will take our usual coffee break at about 11:30, but if at any other stage you wish to take a break, just give me an indication and we can do that.
Thank you.
Please feel that you're in control of the situation.
Okay.
Now, Mr. Connell.
Obliged, Lord. Good morning, Professor Leanord. You have produced a witness statement and a supplementary statement, and subject to a point that I'll add in a minute. Are you happy to adopt these documents as your evidence at the inquiry?
I am.
And the point that I'm adding at your request, I think, is that there was one area where the phraseology that has been deployed, you now think needs tidied up, if I can use that as a neutral phrase. And it's probably easiest if we simply pick that up at a convenient point when we go through this statement.
That is correct, and thank you.
Now, I'll come and ask you about your current position just in a moment. Can I just ask you about one point of detail that's been raised with me? If we go to your witness statement at page 76, and I'm using the electronic page numbers, which will appear on the screen. No, that's the supplemental statement there. It's the witness statement. No, still the wrong one. Thank you. So we go to page 76. It's a point of pure detail. In paragraph 14 on page 76, you say you were clinical lead for the HAI team at HPS. Now, it's been suggested to me that, in fact, Professor Jackie Riley was the clinical lead of that team. Could that be correct?
Yes, I've probably used NHS GGC nomenclature. I would have been the microbiologist for the antimicrobial resistance and HAI team.
So the point that's been suggested to me, that Professor Jackie Riley was the clinical lead, is correct. Is that right?
That's correct.
Thank you very much. And in terms of your involvement, we know that you prepared what I'll call for short the whole genome sequencing report. That's not the full title, but we won't bother repeating all of that. And we'll find that later. It's for the notes in bundle 6, document 40 at page 1195, but we don't need to bring that on the screen at present. But you were acting lead infection control doctor in NHS GGC from November 2019, is that correct?
Correct.
Now, I'm going to use, as I think I've indicated to you in advance, I'm going to use your witness statement as a kind of guide to help us get through the evidence. It may not always mean that we have a logical sequence or a chronological sequence, but we'll do the best we can. Can I just ask you about something that crops up on page 78 of your statement? In paragraph 26. And this is following on you explaining a number of the roles that you had. And you say there the pressing piece of work was to develop a standard operating procedure that described patient placement. as per infection control requirements in the specialised ventilation pressure rooms. Now, I think I'm right in saying that at various points of your statement, you make the point that you don't regard yourself as any particular skills in hospital ventilation. Is that correct?
That's correct.
I think it's mentioned at various places.
I would say I've got a working understanding, but I would not call myself an expert in any way.
And would I be right in thinking, because we've had some evidence on this, as you probably gather, in fact, quite a lot of evidence about ventilation, that in order to create an SOP for patient placement, you would need to understand the ventilation properties of all the different rooms that were potentially available for placing a patient in.
That's correct.
Can you help us at all as to why, as late as 2019, this issue was still outstanding?
My understanding was that there was issues with the ventilation in various rooms. The rooms themselves were quite complicated. Some had HEPA filters, some didn't have HEPA filters, some had lobbies, some didn't have lobbies. And those issues were being worked through. It was very clear that this was a piece of work that needed to be done to ensure patients were placed in the right place, either if they were infectious or if they needed protected. I looked, and we had ventilation engineers looking at all these rooms when we started that piece of work round about September, probably September, October of 2019. And we came up with a document that allowed us and clinical teams to put the patients in the safest possible place within the extant real estate that we possibly could to ensure no risk to patients, staff, or visitors.
As a matter of principle, when should that SOP have been available? At the opening, perhaps?
Ideally, yes. You should have a full understanding of your ventilation rooms, how they were operating, and I would have thought that the infection control team would have been able to use that information to develop an SOP in fairly short order.
Can we go to page 82, because I just want to make sure that His Lordship has an understanding of what your current role means. You say at the top of that page, your role is Chief of Medicine for Diagnostics, Glasgow, and then you say this is a medical management role. But help me, Professor, what's a medical management role?
A medical management role is a doctor who has got some management responsibilities and works closely with the clinical director, sorry, not the clinical director, the director of the diagnostic service, such that we can take issues that are requiring both management skills and financial skills, which would be our director, and clinical and medical skills, which would come through myself.
So is it so far as that part of your post is concerned, is it mainly managing things rather than involved in anything clinical?
That side of my role, yes. My clinical, what's called DCCs, or direct clinical care, now come out of the reference lab, for which I am the director. I do no longer do any out of hours on call for the microbiology team, and I don't do any duty room activity for the microbiology team.
Yeah. So I think further down that page, you say that you ceased doing what you might describe as infection control type work in 2023. Is that right?
Yes, I demitted from acting lead infection control doctor in June 21.
But you were still doing duty hours and out of hours?
I was still doing, that was clinical microbiology, and occasionally I do backfill for the infection control team because they're a small team, and so I will backfill on annual leave. But that's become less and less frequent as that team has grown.
Thank you. Well, perhaps move on from that to topic of the new hospital, which we touch on at page 84 of your witness statement. You asked there a question I think almost everybody has been asked, which is what involvement did you have in the planning and design of the new hospital? And the only involvement that you noted as having was looking at the floor plans for the microbiology department. Is that right?
That's correct.
Did you look at the ventilation requirements at all?
In the microbiology block? No.
Okay, let's move on then. On page 85 of your statement, you say that when the new hospital opened, and I'm generally, if I talked about the new hospital, I'm meaning the whole of the new hospital. I'm not going to say QEUH and RHC every time. When the new hospital opened, you were the clinical lead in microbiology, and you set out various things that would be done at that time. And then on page 86, you say that the biggest concern you had from colleagues was that they had lost their offices. And I think this is something we heard from someone else, that traditionally people are used to having their offices sort of close at hand and they're all put in a block somewhere else, basically. Is that right?
That's correct.
Now, is it not the case that in 2015, people like Dr. Peters and Dr. Redding and so on were reporting, or at least bringing you by way of copy, information about concerns that they had about the new hospital?
I don't remember any specifics. I'm sure they would have if I got copied in. I would have taken that as a professional courtesy that I was being informed. I wasn't directly involved in their concerns.
I'm just wondering, because what you've picked up a point, as I say, that other witnesses have talked about, the business about the offices, but you didn't mention there any concerns about the building or the ventilation in the building or anything of that kind.
Certainly in 2015, I was unaware of those concerns specifically.
I see. And just so we can understand, you were clinical lead in microbiology, but prior to November 19, no infection control responsibilities. Is that right?
That's correct.
I think that's what you say, just so we know where we've got to on page 88 of your witness statement. Now, we know then you did become involved in the infection control process, and we'll come to touch on at least some of the details of that later. But on page 90 of your witness statement, you're asked in question 90, well, here you are, you arrived, you haven't had infection control responsibilities. What support did you get to bring you up to speed? And you say support from within the IPCT from colleagues who had more experience and knowledge of issues in the hospital at that point than I did. And who were they?
Well, I reached out to Dr. Ingster. I needed to try and understand as much as I could the background and the issues, because they were still very much live. The Sandra Devine, who was the acting infection control manager, was very helpful as well. as were her team of infection control nurses who had a lot of experience in the RHC at the time. And there were other colleagues around me who were infection control doctors, not necessarily in the QE, UH or RHC, that I asked for advice from as well, again, to get me up to speed. And as you can imagine, I then refreshed my memory of the National Infection Control Manual, which I hadn't looked at for years.
Any other doctors involved in infection control other than Teresa Inkster? Or is that the name that comes to mind?
I had, so Dr. Peters would have been along the corridor from me. I can't specifically remember if I went to her, but again, Dr. Peters would have had or does have a lot of experience within the issues that I was now going to inherit.
So you can't remember it, but it's possible that you also talked to Dr. Peters about what the issues were.
Yes, and in fact, I do actually remember I also talked to, not necessarily while I was in infection control, but while I was clinical lead towards the end, not 2015, but sometime roundabout just before Dr. Redding retired. She was telling me that she had the concerns about the ventilation system.
Thank you. Now, another name that has cropped up, and in fact the inquiry has had evidence from her, is now I think it's Ms. Harvey Wood, because she doesn't want the title of doctor applied. Kathleen Harvey Wood. Her name is raised with you at page 99 of your statement. And you're asked, well, what concerns were raised by her. Were you aware that she had concerns about the organisms that were being found in 2A and 2B in the RHC?
Not at that time. And as I said, in 2018, I was whole time in the Glasgow Royal Infirmary.
The reason I mention it is obviously, I mean, you know who she is, I take it.
Oh, of course, yes.
And by the time she retired, we had about 40 years of microbiology experience focused almost exclusively on pediatrics. A very experienced person in that field, and she seemed to have been concerned about what she was finding in 2018. You are aware of that generally, are you?
I'm aware of her background, yes.
One thing I did want to ask you about the point at which you became involved in the IMTs. Paragraph 145, which appears on page 101. But I'm going to be picky with you at the moment. I'll just ask you about one word. In paragraph 145, you're talking about Dr. Amelia Crichton, Dr. Crichton being a public health doctor, and it says she was selected to replace Dr. Inkster. Now, can I ask you first of all, what do you know about her selection to replace Dr. Inkster?
Nothing. That's a form of words. You could actually, the sense is that she was there to replace. I didn't know about the background at that time. I was essentially a jobbing microbiologist.
The point I want to ask you about is that Dr. Inkster was removed as chair. Dr. Crichton appears, you appear on the scene at around that time, and at points thereafter you chair various IMTs. There seems to have been an impression on the part of some of the clinicians that the whole approach of the IMTs changed, almost coincidental to that event, from prior to that, focusing on what's the problem, how can we solve it, to after that, how do we prove it's nothing to do with the hospital? Now, that's evidence that the inquiry's had from Dr. Murphy and Dr. Chowdhury. Is that a correct impression?
Having never been to the previous IMTs, I wouldn't be able to answer that.
But you could tell me whether the emphasis after the change was on trying to show that infections were not connected to the hospital.
Okay, I absolutely. So I understand that. I think that's correct. I think that the IMT was trying to put onto strong evidential basis some of the assumptions that or hypotheses that were previously postulated.
Which word do you prefer, assumptions or hypothesis?
Hypothesis.
Thank you.
That were previously postulated, and I also thought that there was a willingness to close down hypotheses that didn't stand or didn't have evidential basis.
I wonder if I can come back to the question, because given the evidence that we've had, I'm quite keen to get your take on it. If the approach of the IMT moved to a focus of trying to show that the problems were not connected to the hospital environment, would that not be the wrong question to be asking?
In a sense, yes. However, if you're looking at a hypothesis that doesn't inform or there is no evidence for, at some point, you're either trying to prove a negative or you have to drop that hypothesis.
I'm sorry to labour the point, but it may be important because I think the argument might well be, if that's what your aim is, that's not you doing your job in the IMT properly. If you're trying to show it's not anything to do with the hospital, that's not what you should be doing.
That's not what I said.
No, well,
sorry.
so please
maybe I. If you have a hypothesis that you have concerns about the hospital, and that hypothesis cannot be shown to be correct, or there's no evidential basis on which to structure or pursue that hypothesis, then I would say you're looking at proving a negative, or you have to accept that that hypothesis does not bear muster.
When you say no evidential basis, do you mean no evidential basis, or do you mean insufficient evidential basis to persuade the person who is making the judgment?
I would say a combination of both. I think both of them could be true. You can start off, I would say IMT is a safe space. It should be a safe space where everybody can contribute. We pull together relevant members for an IMT with different expertise. I believe, and when I've chaired, that any proposal or hypothesis should be and is allowed to be postulated, and then it's up to the IMT with input from the experts around the table about what are the most likely which ones they should pursue and how they would go about either proving or disproving that hypothesis.
Thank you.
In the next paragraph, whole genome sequencing starts to make an appearance, and as I indicated, I'm going to come back to that general topic later on, but if I just, I need to just touch on one or two things at the moment. At that point in time, when you're looking, you say, at Enterobacter and Klebsiella, and I will apologize in advance if I get the pronunciation of these things wrong. How much sequencing of Enterobacter did you do at that time?
In 219 for the IMT?
Yeah.
Not as much as is in the report.
Well, if we just stick to 219 at the
219,
moment,
right.
try and get a picture.
Yes, okay. So this came out of the SBAR that Dr. Peters and Dr. Inkster presented to the IMT showing Enterobacter increasing. I realized, and I think it was my second or third meeting, I realized that we had the ability within the reference lab with both expertise and equipment to try and show what was happening behind these bar graphs that were there, either to identify transmission or to show that transmission was not an issue.
I'm just trying at the moment to get some kind of flavor for, you know, how much did you do at that time, where from, and so on.
So we looked at, we needed to do it at pace because I wanted to use it to reassure the clinicians. We looked at, I would say it got chunked up into weeks. The first week we would have identified as many Enterobacter as we could lay our hands on by interrogating the laboratory system, going into freezers, pulling out organisms. Week 2 would be growing the organisms, ensuring purity, extracting the DNA and sequencing. Week 3 would have been quality control of that sequencing output, and week 4 would have been the analysis and presentation at that time.
And if you can't tell me at this distance, please just say so. Can you tell me, you know, how many samples of Enterobacter you sequenced at that time, and whether these were from plates or from environmental samples?
They were mostly from clinical samples at the time. I don't remember exactly how many isolates we managed to identify in that first week. I can give the inquiry that information. It's on my laptop out with this room. But it was very clearly an ad hoc analysis that was done quickly for a very specific reason.
Yeah, I think the issue, as we know, is what significance you can draw from the various results. And as I say, I'm going to come back to that in more general terms. But I think it might be worth pausing just here to ask this question. There seem to have been, at least there appeared to be, and I'm using that phraseology specifically, an upsurge in these two organisms, and then they disappear later. Now, do you know why that is?
Enterobacter and Klebsiella.
Yeah.
My own view is that when you look at the antibiotic use, I think the broad spectrum antibiotic use was a driver in the fact that we saw not necessarily only those organisms, but other organisms as part of this outbreak. It's not the only reason, but I think there's multifactorial reasons. And for Enterobacter and Klebsiella, I think there's a strong drive from antibiotic selective pressure.
Sorry, give me that again.
From antibiotic selective pressure from the broad spectrum antibiotics that are used in patients.
And the antibiotic is selective as to which organism it...
So Klebsiella and Enterobacter and Stenotrophomonas, I think there are signals in the data that will show that these, when you put somebody on a broad spectrum antibiotic, you quite radically change their microbiome, their gut microbiome. And if you have organisms that are resistant to that antibiotic, they will overgrow and predominate in that microbiome. And therefore, you have a higher concentration of these organisms within the microbiome. And when I mean microbiome, I'm talking about essentially your guts. And then those organisms would predominantly, if there is gut translocation, would be able to enter the bloodstream, and they would be the organisms by which you would see the infections occurring with.
Right. You'll have to excuse me for my rather ignorant approach to this. So that if a patient group is receiving prophylaxis,
Possibly, or even treatment.
Or treatment by, I think you said a broad spectrum antibiotic?
Yes.
One would expect that will be effective in respect of some of the microorganisms in patients' biome, but not necessarily others, and therefore the others unaffected by the antibiotic will begin to predominate within the biome. Am I following this?
Absolutely correct.
Right. And if you've got a larger number of a particular number of particular microorganisms, then if there is transmission from the gut to the bloodstream, it is more likely that the transmission will be by these predominating microorganisms.
Correct.
Right, okay. Thank you.
There is another part of your witness statement in which we deal with the same issue in the context of Stenotrophomonas, which we'll come to in due course.
Correct.
But I just want to try and understand that proposition, because if this is all to do with the prescription of broad spectrum antibiotics to a patient cohort, which we were dealing with here, because this was 6A, which was the people who had to move from another ward, would you not expect the pattern to continue?
So my supposition is it's not all to do with antibiotics, but I do believe antibiotics played a part. My view is that this is multifactorial. I think antibiotics stewardship played a part. I think the built environment played a part. I believe that possibly patient acuity played a part.
Sorry, patient?
Acuity, how sick your patient is. It's possible that patient numbers played a part, such that there was more activity, and also the way that the patients were cared for. I'm not saying any of them predominated, but all of them could have.
Yeah, I'll leave my further question to that. Can we come to Stenotrophomonas, because there's a twist with that one. Can I just ask you, when you were doing this at-speed exercise. Did you discuss these issues with, for instance, Dr. Peters?
No,
Any reason why not?
I had no contact at that time with Dr. Peters.
She was one of your clinical microbiology colleagues at that time, was she not?
She was, but I was based in another hospital. I'm doing a different role.
Thank you.
Again, I apologize for my lack of understanding of these things. The first step in your 4-week program, I've noted, possibly inaccurately, as pulling out the Enterobacter results. Now, I think you explained that these were largely or exclusively the results of blood sampling of patients. Am I right?
At that time, it would have been exclusively the sampling of the blood sample patients. So these patients would have had an Enterobacter bacteremia.
Right. And these samples were recent samples?
No, not necessarily. They would be stored samples. Our normal procedure within the microbiology departments is to store in -80 freezers all positive blood cultures. And we have an archive system that you can access and identify those samples, retrieve them, culture them, and do whatever further testing you would like to do on them.
Right. So because of the low temperature, the sample will be presumably maintained in its condition when it was first sampled.
Absolutely, and it's also in a cryopreservative as well. And so the cells will sit there frozen and in a cryopreservative, and then you I was going to say bring them back to life, but you culture them, and generally speaking, the reculture rate is very high, 80-90%.
And when you talk about reculture, it revivifies or becomes active.
Absolutely.
Right. Now, you said that these were not exclusively recent. What sort of period of time?
We would have looked from 2015 to the current date. And it would be pure serendipity about what initial isolates the technician could put their hands on over that set period of time. We did a more extensive search latterly when we had the fullness of time, when we wanted to sequence a broader range of Enterobacter. And that did include some environmental samples, but very few with Enterobacter.
Serendipity. Do I understand that not all samples from 2015 through to 2019 will have been archived in this way?
Correct. You never get 100% complete collection for whatever reasons. Either they've died, they haven't been put in the right place in the freezer, or somebody has forgotten to follow the SOP and preserve them for potential further testing.
Appreciate that it's not a question that can be answered precisely, but what sort of proportion of the number of samples which were taken from patients in that period are archived?
Mid-90%.
Right. Okay. Thank you.
Yes,
Sorry, Mr. Connor.
While we're on this area, I've been asked to ask whether you're aware of the term opportunistic plumbing pathogens. Is that one you've come across?
Only through this inquiry.
The question is whether the two organisms we're looking at here, Enterobacter and Klebsiella, are within that group.
They are, but throughout this outbreak, they have been exclusively placed within that category, whereas I have always understood these organisms to be enteric.
Just tell me what the difference is then.
Well, if you have an infection with either of these two organisms, you could either plate their source could be from the plumbing, as you've described with an OPPS, OPPP, or they could be from the patient's own endogenous flora. Throughout all the analysis I've seen from this during this inquiry, both those organisms have been placed within the environmental stroke enteric group. And I've never seen any suggestion that these were looked at individually to try and ascertain whether they have come from the environment or whether they have come from the patient themselves.
Right, my fault entirely. I should have got this immediately, but I didn't quite hear Mr. Connell's description. The two microorganisms that we're discussing at the moment are
Enterobacter,
right, and that's the whole genus,
the whole genus,
right,
and Klebsiella,
and Klebsiella,
the whole genus.
and do I understand, again, if I'm following things, the source of both these genera may be environmental or may be enteric.
Correct.
Right. Thank you. I just want to make sure that I'm keeping up. Mr.
And
Connell.
If they're enteric, can they then potentially enter the drainage system and cause infection to others?
Of course, and that's how the environment itself would get propagated with these organisms.
Okay. Yeah, if we could move on. I want to ask you about a slightly more general point. I was going to move on to page 104, but in fact, I'll do that anyway, but I'm not sure the point necessarily relates to that precise moment in time. I suspect it's a much earlier point that I should have asked you about. The suggestion's been made that the relatively early stage of Dr. Peter's involvement in infection control at the new hospital, she was in conversation with you because you were her clinical lead, or whatever the right phrase is, and she was explaining some of her concerns about the building and what was going on in infection control. Now, first of all, do you remember having a conversation about these topics with her?
I do not.
The suggestion then is, and I need to ask you about it nevertheless, the suggestion then is that in the course of that conversation, and I'll say immediately, explain without any apparent ill intent, you said something to her along the lines of, "Why put your head above the parapet?" Do you have any recollection of saying that?
No. However, it wasn't unusual for colleagues to have conversations with me. I would have taken that as almost like a pastoral conversation where at that time, a junior consultant, not that such a thing exists, was having a conversation with myself, who was slightly longer in the tooth, and I may have said, not that I do, but I can imagine myself saying that, you do realise that this will not be an easy path to tread, or words to that effect.
Yeah. I mean, I think that, as you'd have no direct recollection of the conversation, it may not matter. I think that the phrase "pipe down or you'll find things tough or things hard," something along these lines was suggested as a possible communication, and you recognise that as a conversation you may have had.
Yes, but that particular phrase is an instruction, and that I wasn't in the business or the place to instruct anybody, certainly not a consultant colleague, about what they thought best to do.
Yeah, I think it was, at least as it was explained to us, it was taken as not as a threat or an instruction, but simply as an indication that if you keep raising these concerns, that could be a difficult road.
I don't dispute Dr. Peters' recollection of that at all. On that basis.
Thank you. Well, I think I can move on then to another issue that predates your infection control lead role in the IMTs, because I think the suggestion is that there were quite a few problems, or said to be quite a few problems, with the way infection control was being run in the new hospital. And this was concerning those who were involved with it. Now, the first question I've been asked to put to you is, as soon as you got to learn about this, is that not something you could have sorted out from one of your previous positions, for instance, the HAI policy group, if there was some problem over, for instance, clarity of roles for ICDs?
Whilst I was in the Scottish Government?
Yeah.
I was involved in work in the Scottish Government about trying to define that very point, the clarity of roles within an ICD. And we went round, so we had a number of meetings with what was called the Infection Control Network at the time. There was a paper developed at the time, but it never came to fruition. I'm not quite sure why, or either I left before it did come to fruition. I give this information to inform the inquiry that that thinking had occurred at the Scottish Government, and a piece of work was progressed along those lines.
Do you remember attending a meeting with all of the consultants in infection control with Mr. Gardner in September of 2019?
Yes.
Now, I'll put the notes up just in a minute. It's dealt with in your witness statement at page 105. I suppose the general question I have, given what you were hearing, did this bother you?
Did it bother me at the meeting?
Well, was this a matter that concerned you once you heard about it?
Of course, I took it very seriously.
What did you do about that then?
First off, I listened. I needed to understand exactly what the concerns were. I've seen the notes of a colleague in the bundle, and they more or less match my contemporaneous notes at the time. I've got no issue that what was discussed was discussed. I recognised that as clinical director at the time, I had a responsibility, along with others, to try and see whether we could fix this. I use that term loosely, but there was a problem. It was very clear what the problems were. It was to do with complexity of the workload, the scale of the workload, the feeling that there was not the skills within the full team to deal with the issues that the QE and RHC were throwing up, that there was a disconnect between the infection control team, IPCT, and by that I mean some of the nursing staff and the ICDs, there was concerns about accuracy of information, and there was also concerns about pressure to sign off workload. And the most fundamental issue that struck me was that my microbiology colleagues had resigned their infection control sessions such that there was no effective infection control cover for that campus. Not only that, but two of our most experienced and well-versed colleagues, Dr. Ingster and Dr. Peters, had demitted office. And so we were going to lose a wealth of experience and corporate knowledge about the issues at stake.
I think in fairness, and because it may help the way the inquiry is recording the evidence, I'll just put up the note, if you don't mind. This is in Bundle 27, Volume 4, page 354. Now, I think you've indicated you've seen this before. You've no issue with it. It broadly matches your own notes. That's your evidence today.
Absolutely.
Yeah. I tried to have a look to see what your contribution was, Professor Leanord. I think there's one reference on 355, because your AL, where you're saying the ICD role definition was never defined, and one or two other comments there, including reference to some of the specialist areas that you're now encountering. And then on 358, I think there's another one or two comments. Interestingly, near the top of the page, you say there's obviously an issue with the built environment. We're in a new area of how we deal with environment. And then you say you're not entirely convinced that what's in the environment is what you see in patients, it's possible. So that was possibly the start of an exchange on that topic back then.
Yeah, possibly. I was certainly in active listening mode during those meetings.
Thank you. I think we can leave that a minute. Thank you very much. If we can just go to another point. Some of these, I'm afraid, by the nature that we're jumping around a little from topic to topic. 107, a statement. Now, what we're dealing with there is a decision on the safety of Ward 6A, which you touch on in paragraph 170. Now, what's said there is, as per the inquiry, what view Professor Jones and I reached on the safety of Ward 6A from a microbiological perspective. And you answer that by dealing with water testing results. Now, I suppose the question is, does reviewing water testing results allow you to say whether the ward itself is safe?
No, and you're absolutely right to point that out. From a microbiological perspective, I was saying that the water was safe. I could not opine on anything else at that meeting, as I had no data or information around about, for instance, the other hypothesis that was still in play at that point, which was the chilled beam units. I had no experience of them. In fact, I've never even seen a chilled beam unit. I wouldn't know what it looks like. And I certainly didn't have any data on that. So specifically, I was giving opinion on the safety or the wholesomeness of the water.
Did you visit the ward to help you form a view?
Not at that time, but I had visited the ward.
But not for the purpose of this discussion?
Not for the purpose of that discussion. And in fact, the information I would need would not necessarily, for water safety, would not necessarily be there.
And as you say in this paragraph, one of the issues was that point of use filters had been fitted in that ward. So whatever was in the water, if there was anything in the water, wasn't going to reach.
Absolutely, there were 0.2
Beyond that.
micron filters, so they were the last mechanical barrier to anything bypassing either the chlorine dioxide or the water management system that was there in place.
If we move on to 109, in paragraph 177, when we're discussing what was or was not happening, you say, but halfway through 177, my recollection is that the same environmental organisms were seen in infected patients in York Hill as were being seen in the RHC. This is partly why I asked you about Miss Harvey Wood earlier, because her evidence was very much to the contrary, that she was seeing very different things in the new hospital to what she saw in York Hill. And that seemed to be what clinicians were saying as well. Do you have any views on that?
So they were broadly similar. We saw, if you like, the big ticket organisms were there.
What do you just so we understand what you mean by that?
So Enterobacterus, Klebsiella, Stenotrophomonas, for instance, were on both sides. I have seen in the bundle Dr. Harvey Wood's, Miss Harvey Wood's data. That is count data. I've got no reason to have any concerns about that. The data is what the data is. The only thing I would say is that between periods from the old York Hill to the new York Hill, or so to RHC, or between 2013 and now, we changed the way we identified organisms to a far more specific methodology. And although the methodology has not changed, there have been software upgrades between those periods, which could have allowed for better identification to genus and species level than we previously had.
As a matter of generality, if you're looking between, we know that, for instance, the what became Ward 2A moved from York Hill, sort of lock, stock and barrel, at least that was the theory. Is it right to compare the brand new flagship super duper hospital with old York Hill?
Yes, because that's all you have got to compare. If you are looking at whether there was a change for better or for worse.
And was water testing done in York Hill, do you know?
I'm sorry, I don't know.
Okay. Well, if we look at the next couple of paragraphs, in 179, you say you think the idea that water and air is contaminated is a misconception. And you make the point that water is not sterile. Is it correct that when you're dealing with immunocompromised patients, you have to pay particular attention to the extent to which there are organisms in the water?
I would say that water would be a risk, and therefore you would
I wonder if I could just ask you about this, Professor. Would I be right to read your statement as challenging the whole concept of contamination, or are you saying something else?
I've got a very specific definition of contamination. Contamination is something within wholesome water that either pollutes it or makes it toxic or dangerous such that it cannot be ingested. That's what I would take as, and that could be either by chemical agents or in some cases organisms. There's a level down from that where I would accept that aquatic organisms that you would normally see, for instance, Legionella and Pseudomonas, because they have got a infective potential within humans and are maintained partly by engineering controls, I would also say that's contaminated. What I don't think, or the harder definition is when you have normal aquatic organisms that go about their aquatic business in buildings probably like this and in healthcare buildings. At what level does too many of them become a contamination, or even can it be called a contamination, or is it an out of specification? And I think there is no criteria set that I'm aware of, or that the authorizing engineers have let us be aware of, that would set a level that would be deemed, that would tip you from safe to unsafe with these aquatic organisms. And then we get into the risk profiles of the patients themselves, and that's where the risk comes from, as well as potentially some of these organisms might not all be the same in terms of the potential to cause infection. And we might touch on that later with the sequencing.
Right. What I'm taking from that is that water, for example, containing microorganisms which have pathogenic potential, in other words, which may be the source of infection in certain populations of patients, you would accept as a concept that a high level of such microorganisms might allow the water to be described as contaminated, but you point to the absence of hard definitions of where, on one hand, the water is as you expect it to be, and on the other hand, because of the high concentration of potentially pathogenic microorganisms, it could be described as contaminated. Or am I wrong about that?
I think water can be a risk dependent on the patient risk factors. You could have a very low concentration of a pathogen an organism in the water, but you could have very significant breakdowns in standard infection control procedure such that the organism is transferred to the patient who's then susceptible. There still has to be a link for transmission from the water into the patient, and the concentration could be important. I don't know the evidence for that, but poor practice would be just as important, as would patient susceptibility to infections. So I don't know that I could actually, and then maybe this is the issue why no one can say when there's a water system that's got normal aquatic organisms in it tip from being safe to unsafe.
I've noted down, because it seems to me a very important statement from someone who is an expert in the area, that the concentration of microorganisms could be a factor, but you don't know the evidence for that. Now, to the ignorant layman, that's surprising, but that is the expert position, is it?
I know, I would say that I can imagine circumstances where low concentration of water could infect a patient, depending on what the chain of transmission is. You would logically think that a higher concentration of organisms would be easier to transfer along a chain of transmission, but that's not necessarily the case. If somebody's practice, their infection control practice, their standard infection control precautions is poor, then it doesn't matter about the concentration because you've still got a possible link of transmission.
I can see that, or at least I think I can see, that one has to have regard to various steps along the potential pathway between the organism and the patient. But
where concentration is a factor for water.
right. As you recognize that to the ignorant, that's counterintuitive.
Yep.
Right. And to the ignorant, the fact that total viable count, I appreciate this is a very rough and ready indication and it's not specific to organisms, but to the ignorant, the fact that, for example, as a definition of wholesome water, total viable count, if I understand things correctly, is of relevance. If concentration is not or has not been shown by the science to be a factor, why are we interested, for example, in total viable count?
So total viable counts is a very useful surrogate for the health of a water system. But in one of the documents that this inquiry has from Dominique Chapeau, who was one of the infection control clinical scientists, when you look at TVCs, you will find that organism growth will occur in 50% of the samples, approximately 50% of the samples that have passed a TVC threshold. So TVCs do not tell you when you're looking at named organisms, whether those named organisms are present in the water or not. The value of TVCs is a trend value. One-off TVCs do not help you, and you watch a trend in a system, and you will see TVCs increasing when a water system is poorly performing. But it's not a marker for whether aquatic organisms are there, because even those who are below threshold, you will still have those aquatic organisms. Now, I will put a big health statement on that if I can. The way that Glasgow measure TVCs in organisms are different. TVCs are defined as a number of organisms per mil. When we're looking for named organisms, Cuprovidus, for instance, Phingomonas, Delphias, Acidovorax, the A to Z of environmental organisms, we take 100 times that concentration and we filter that down and we find however many organisms that are there. And it may only be handfuls, it may be 5 or 10 or 6. So if you were actually to look at that by per mil as a way that you measure TVCs, you would not see these organisms. So we have taken a 2 log increase in the concentration, sorry, in the volume of water that we use to try and identify these organisms.
Right. So what's the bottom line on that particular?
So
I mean, I introduced TVCs to really to disclose that you're the expert, I'm not. To the layman, the fact that one is interested in the count, even if the count is indiscriminate, in the sense that it's everything, as an indicator of the wholesomeness of water, suggests to the ignorant person that the concentration of microorganisms is of importance. Now, if I've noted you correctly, you say that is not supported by the science. And that is, I want to make sure I've got your evidence correctly.
So TVCs are a marker of system health, and they're measured per mil. And we have got breakpoints or where an out of specification becomes important, and you would do something about that. When we're looking at aquatic organisms, we're taking 100 times more volume, and we are actually going hunting. We are searching for these organisms. And you might have, for the sake of argument, you filter down 100 mils of water, and you might have 5 Cuprovidus on your filter plate. Now, if you were to take 1 mil of that, your probability of having 1 Cuprovidus in that is, well, we can do some fast maths, but I can't at the moment. But so you would not find these organisms if you took smaller volumes of water. The reason we take high volumes of water is because that's what you do when you look for Pseudomonas, etc., which have got significant problems if they're in your system. So when I'm talking about high concentrations, we're talking about quite low numbers would still be deemed to be high concentrations because you've taken a larger volume of water. So it would be low absolute numbers would still be in a system that could be contaminated, depending on how you define contamination.
Right. Well, thank you. Mr. Connell, I'll leave that there.
If I'm picking that up correctly, one of the reasons why you're hunting for these is because the kind of things you're hunting for can have adverse effects if they get into the patient's system. Is that right?
Correct.
And therefore you want to know, are they there, and how much of it is there if you can? Indeed,
and does explain some of the infections that we could be seeing in the patients.
And I assume that's why organisations like NHS-GGC has a very stringent water policy about the amount of bacteria that's acceptable on various kinds. Is that right?
Yes, and that was that's been in place since Ian Powery and Dr. Ingster came up with those definitions. And when I took over as lead, I saw no reason to change them, recognising them that they are very stringent and far in excess of what would be industry standard normal, and probably far in excess for what other health boards are doing.
And it's one possible explanation for that that a lot of the issues that arose in the new hospital arose around wards which were occupied by particularly vulnerable patients, to avoid getting into a debate about what's neutropenic or not.
Yes, I don't. I agree with that.
Yeah. And that's presumably also why the water system in a building as complex as the new hospital was designed to have a lot of checks, balances, precautions, and so on, in order to avoid organisms growing that could be detrimental to health. Is that right?
That's right. You want good system health.
I just ask, almost everybody's been asked about this, whether they were there at the time or not. Are you aware of the findings of what's been called the DMA report of 2015?
I was not.
This is a slightly different question, but am I right in understanding at the time you're working on the infection control team, the dosing of the system with chlorine dioxide had started?
It had. I believe it started at the beginning of 19, so it'd been active for a period of 9 months.
Do you know whether that's a process which selectively gets rid of some bugs, but perhaps thus encourages others?
We do know, because of the recommissioning of 2A, that there are chlorine-resistant organisms, which we found when we were doing recommissioning work. Off the top of my head, I think they were Sphingomonas, Acidivorax, and Delphtia are all chlorine-resistant, or more chlorine-resistant, I should say. Sorry.
So the effect of chlorine dioxide dosing is not immediately to eliminate everything, because some things are more resistant to being eliminated than others.
Yes, but what I don't know is although it may not eliminate, it may significantly decrease the bioburden within the system. And you have the persisters who are chlorine resistant still residual there.
And are some of the residual organisms ones that are capable of causing illness in vulnerable patients?
I guess any organism potentially could. I can't remember if Sphingomonas was one of the organisms that got looked at as part of the case note review. I don't think we've. I'd have to check to see if any of those organisms had been seen in patients. If they have, it's a handful. But I don't know the answer to your question off the top of my head, sorry.
I'm not so much concerned with whether they in fact infected a patient.
Oh, could they? Yes, yeah. Any organism in a system could.
I'm going to come back to your whole genome sequencing proposition later, but as we happen to be, as it were, passing it at this stage of your statement, can I just ask you a couple of things about page 110? You've talked about Cupravidus, and then in 181, when you're talking about gene sequencing, you say there's a stable population. Now, can you help us understand what you mean by a stable population?
They were, Cupravidus forms into, all organisms basically, when you sequence them, fall into what we call clades, which are, think of them in lay terms as a family. And there are clades or families of Cupravidus that are resident in the water system in RHC, that are closely genetically related, have been there for the period that we tested them, so that would be a 3-year period, and are distinct from 2 other families that sit within the hospital system as well, who of course are genetically related and so forth.
When you did the sequencing exercise that led to the report that we've got before this inquiry, was that just done in the, we call it a lab, just to use a layman's terms, that you were using, or did you get it checked by anyone else?
So the sequencing report in this inquiry has not gone to peer review. I don't think it could go to peer review in its present form. It was done by a very experienced clinical scientist with myself inputting.
No, it was just a factual question.
Oh,
I just
sorry.
wanted to know what the answer was, and that's very helpful. Thank you. I think just while I'm on, we've been sort of touching around York Hill. Do you know what steps had been taken in York Hill to deal with things like Pseudomonas and so forth?
I'm sorry, I had no knowledge of York Hill at all.
Thank you. And if we just stick to Cupravidis for the moment, you say in paragraph 183 that there's no agreed level, and that's something that you've been touching upon with his lordship. So would I be right in understanding from the answers you've already given that we don't know what level of Cupravidis could cause infection in an immunocompromised patient?
Theoretically, it could be one. It could be one organism, but that would have to have a perfect train of transmission. But we don't know what the infective dose is, and we don't know what the concentration in the water would look like. That would be considered a fundamental risk, and we also don't know if all these organisms are the same. We've got a signature in Stenotrophomonas that some of these organisms are more capable of causing human infections and some don't. Some are environmental. They do not have the requisite genes within them that allow them to invade and sit and fight against our immune host system. So for Cupravidis, I would say we don't know enough. We're starting that journey on trying to understand these organisms, but I wouldn't be able to say anything more than that. It's very early.
It's not, or wasn't a particularly common organism to find, is that right?
Well, it is. It's not very common because people have never looked for it, but if you look at a piece of work that came out of Glasgow, every city building that had tankage has Cupravidis in it. When you look at other hospitals, again, a piece of work which was done by Dr. Engster, 63% of other hospitals had, or samples from 10 other hospitals had these types of organisms within them.
Now, if you're trying to protect in that state of knowledge a potential patient cohort which is more vulnerable than the average, you would need to, presumably, to try and prevent them, if possible, having contact with anything with Cupravidis in it, because you don't know how much is going to cause a risk, is that right?
I would agree.
Can we move on a little? We know there's a report by Dr. Kennedy. I'm not going to ask you about Dr. Kennedy to speak to that report. We've heard already. So if we move on to page 112 of your witness statement, Dr. Kennedy produced some information about the water incident, or we're calling the water incident, in March 2018. In paragraph 191, you say that the peak in a particular curve was most likely multifactorial, but you thought the likely source of infections with Klebsiella and Enterobacter was due to translocation of the organisms from the bowel, so not from the environment at all. Is that what you're saying there?
So I've thought about this. We haven't found either Klebsiella or Enterobacter in the water system, apart from 6 or 4 organisms. So they are not in the potable water. If they're in the environment, the theory would be they come from the drains. With drains, as soon as you wash your hands or your body, that drain will then become colonized with those organisms, your own flora. And then we've got the issue of directionality. How do you differentiate between the drain, the organism in the drain getting into the person, or the organism of the person getting into the drain? So if we were to say that, to do a thought experiment and stated, let's assume that the drain is being colonized by the organism from patient A. Patient A is not going to get infected by that organism, that's their organism. So patient B now needs to come in, and there needs to be some transfer from the drain into patient B through a chain of transmission. The alternative is you have these organisms within your own body, and they can translocate and cause an infection in a place that they shouldn't be. Now, if you apply Occam's razor, where the simplest explanation is usually the best, I would state that it would be easier to understand how you have got a large concentration of these organisms already within your body, rather than stating that it has to go outside your body, into a drain, out of a drain, through a chain of transmission, back into your body. And so in that basis, and the basis that the Enterobacter sequencing, to my mind, does not show sporadic infections, I think, and it's my opinion, that these organisms are translocating through the bowel, and in some cases have got, as a result of 2 things, their treatment and potential antibiotic selection as a result of either treatment of infection or prophylaxis.
If these are processes that are naturally occurring, they would happen all the time, wouldn't they? If this is just something that comes from the patient's gut, you wouldn't get variations, because unless you get very odd patient cohort, you get roughly the same results all the time, would you not?
If the same selective pressures were there constantly, but there is information in front of this inquiry that shows that that's not the case.
What do you mean by that?
If you look at the antibiotic use over the quarters, the last 2 quarters of 2017 and the first quarter of 2018, the DDDs, actually, which is a measure of direct dose, goes over 2.5, increases 2.5-fold at that period. Meropenem increases 2-fold. It all falls down. That increase of antibiotic correlates clearly with the peak of infections in the autumn of 17 and spring of 18, and in fact is actually evident in Dr. Harvey Wood's data as well.
Right.
So
I didn't get a note of that.
no, let's make sure we're understanding it. If I understand it, what you're basically saying is the cause of all the problems that we've been looking at has been prescription of antibiotics.
No, and I'm not saying all the problems. I'm saying that can play part of the problem. I think it's multifactorial, and that would be some of the explanation, but not all of the explanation.
I don't know if you're in a position to provide it, Mr. Connell, but I will need the source of what Professor Leanord referred to, as much for my notes as anything else.
Can you give us that bit again, the bit about the rates that were noted with the link to 2017 and 2018? If you just give it a little bit more slowly, so it may be important, so His Lordship needs to note it.
So the question was, if this is happening all the time, if this is happening, it should happen all the time. My opinion is that it hasn't been happening all the time, and there has been selective pressure. When you look at some of the broad spectrum antibiotic use in quarter 3 and 4 of 2017 and quarter 1 of 2018, you will see a 2.5-fold increase in the broad spectrum antibiotic tazocin, or piperacillin tazobactam for its proper name, and in the first quarter of 2018, a 2-fold increase in meropenem use. Both those antibiotics are capable of, as we've talked about, changing the microbiome and selecting out resistant strains, of which Klebsiella, Enterobacter, and Stenotrophomonas could be selected out, especially Stenotrophomonas after carbapenem use, after meropenem use. This is not all, but part of the picture that we see.
Now, it's for us to find the references, but where should we be looking for the data which allows you to draw the conclusions about the increasing use of
So they are from, I have that information, which is from Isabel Gurley, who's our antimicrobial pharmacist, but also graph 12 of Ms. Harvey Wood's presentation, shows some of that information as well.
Right. And I mean, you said this was information in front of the inquiry. Is this a document that?
Well, it was Dr. Harvey Woods. I'm not sure it was.
We've got Dr. Harvey Wood's
yeah.
presentation. I
Oh,
think it's
so-
the other one we're checking for.
So the other one would be the reference for the meropenem use and a increase in Stenotrophomonas. Well, it's well known. Professor Dancer has already mentioned it to this inquiry, but I think the reference is Tane. I can get the exact reference to you and give it to you.
Right. So this may not be a document that we have yet.
No, sorry, not. This would be in the published literature. The document I was referring to was Dr. Harvey Wood's document,
Right.
graph 12.
Did you refer to a document produced by Miss Gourley?
No, that's data that I have, but it is in some of that information will be in Dr. Harvey Wood's graph 12.
Right. Could we ask that possibly with the good offices of CLO, if at an appropriate moment you ensure that either we get the reference, or if it's an additional document or an additional journal article, we get that.
I will do.
Right, thank you. Would this be a moment to
Yes,
take our coffee
of course.
break?
Yes.
I'm not suggesting you need to do this over the coffee break, but if we get this information in fairly soon, could I ask you to be back for 12 o'clock, Professor?
Absolutely.
Please stand.
Mr. Connell.
Mr. Lord, can I just go back on one point that you mentioned earlier? We were talking about patient A having an infection in their gut, and they can't get it. It goes into the drains and possibly infects somebody else if you can provide a route for that to happen. Is it not the case that patient A can be infected with something that comes from their gut?
Yes, indeed. If it's translocated, yes.
That's why we wash our hands, isn't
Yeah.
it? One of the reasons.
No, actually, you wash your hands after. That's altruistic. You are ensuring that your organisms don't go onto any of the sanitary ware, so that the next person picks it up.
But also, they don't go into your mouth if you happen to.
But then
pick
you
them up.
won't. But they're already in your gut. All you do is have a nasty experience in your mouth. It's not. You wouldn't. You can't reinfect yourself with your own organisms, unless there's a breach in your anatomical barriers.
That's an interesting insight, that washing your hands is altruistic as opposed to selfish. No, I'm interested. Sorry, Mr. Connell.
The other thing I've been asked to put to you is talking about antibiotic prescription. But the antibiotics not being prescribed because people were getting all these infections. It's not they were getting infections because of the antibiotics. They were being prescribed to deal with the fact that patients were getting infections.
Yeah, absolutely. But it doesn't remove the selective pressure, and also a lot of these antibiotics that were being prescribed are prescribed empirically, because in this patient cohort you have neutropenic sepsis, and you do not know what the organism is, if there's an organism. If you take blood cultures, you'll get that result 48 hours later. If it is positive, in many cases it's not positive, and you will find, for us, certainly in the case of Stenotrophomonas, you will find colonization and selection of that organism as a result of your broad spectrum empirical antibiotics that you started because of a neutropenic sepsis, for instance.
I'm going to come to Stenotrophomonas in a minute, because I'm going to suggest it's in a slightly different category to Klebsiella and Enterobacter.
I agree.
Just looking at this idea of translocation as well, you say it's multifactorial, so it's not the whole answer, it's only one of the answers. Is that right?
So antibiotic selection pressure, or antibiotic stewardship, as I would say, is one of the potential answers, yes.
If you're looking at this idea that an infection, say with Enterobacter, has been caused by translocation from the gut, presumably you could test that by taking a fecal sample and subjecting to whole genome sequencing and then determining whether you get a close enough link.
You could. One of the challenges of that is the high bacterial concentration in feces. You've got 100 million, is that a US billion organisms per gram of wet feces? A gram of wet feces is roughly something around about the size of a peanut. So you would need a reliable way of screening for that organism, and a reliable way of testing for it. So you could validate it. So every time it was there, you got it, so you didn't miss it. The other difficulty is that we do carry multiple strains of organisms within our gut. So you may have one on your Petri dish that you're going to test, and it might not be the one that is actually doing the infection. But the concept as you describe it, is correct.
And did you do any such testing?
No.
Can I just ask you then, just so we understand what you've been referring to earlier, to look at Dr. Harvey Wood's graphs, and then you can tell us which one you're looking at and what you take from it. This, I'm told, we should find in her PowerPoint presentation, which is Bundle 27, Volume 6, page 103. Yeah, that doesn't seem to be the correct reference. What's the reference I've been given? Oh, there we are. Right, now, we know we have a series of graphs coming. Did you say it was graph 12?
I think it was graph 12. It's beautifully multicolored. Not that one. Not that one. Not that one. That one.
That one. So this is prepared in 2018. And what do you say that we should take from that that's helpful?
So there's 4 lines that to look at. First, the first line is the solid yellow line with triangles, which is meropenem use. And then we'll take this with, and then the next one is yellow lines with dots, which is meropenem resistant environmental gram negatives, and so you can see that from a DDD point on in the fourth quarter of 2015, you can see a steady rise of over 150 DDDs into the first quarter of 2017. And attendant with that rise, you'll see an increase in the little yellow dotted line from 0 at 2016 in the first quarter, slowly rising up to the fourth quarter in 2016, and then going up to 5 in the second quarter 17 and the third quarter in 17, just after the peak in meropenem has gone up to the first quarter in 21. Then it drops down again, and then meropenem goes back up from about 220 DDDs above 400, so it's almost doubled. And you see a consequent increase in the first quarter of 2018 and the second quarter of 2018 in meropenem resistant organisms, so that it's 4 and 5. When you look at these numbers, such that they're at the rate of 5 in the second quarter in 17 and the third quarter in 17, out of a total of 13 organisms, that then takes, that's well over 30%, almost 40% of your organisms are within that graph. And then if you look at the second quarter, the last bar in 2018, it's at 5, and that's of 16. So that's about 30% of your organisms. So somewhere between 30 and 40% of your organisms are meropenem resistant environmental gram negatives. And my opinion is that that's driven by the increased use of meropenem as a result, selecting these organisms out. And I would guess, I don't know what the organisms are, but I would guess that they're all Stenotrophomonas. So that's for meropenem. The next graphic is Tadocin, and you're following the blue line, the solid blue line, and then there's a dotted blue line. And you can see from the fourth quarter of 2016, Tadocin antibiotics is at 200 DDDs, and then it rises in the third quarter of 17 up to above 500. So it's more than doubled. It's 2.5 times what it was in a 12-month period. And you can see the dotted line, you can see in the second quarter of 2017 from a standing start of 0 to the third quarter of 2017, the dotted line, the blue dotted line goes up to 5 organisms, and they are the Tadocin resistant environmental gram negatives, and then it drops down again once Tadocin use comes down. So I would guess that's either going to be Enterobacter or Klebsiella. And so that's 4 organisms out of in the third quarter of 2017. So that then, to my mind, then the total in 2017 is 13 organisms. We can attribute 5 possibly to selection out of meropenem, 4 because of selection out because of tadocin. So of those 13, we can maybe have an explanation for 7 of them. So over 50% of that increase, I think, can be explained by the use of antibiotics. The other 50% could be other things, but I think this is clear to me and has been written in the literature, and it wasn't Tane. I looked it up while I was in recess, and it's Aitken in 221 describes this, and I'm happy to share that paper.
I think that would be helpful. Is it right to say that the cohort of patients in the pediatric hemato-oncology unit tend to have a high proportion of meropenem anyway?
They do.
Because of the nature of resistance and allergies and all kinds of other things.
Absolutely, and that's one of the So when you use these antibiotics, you will, because of their powerful nature and their ability to kill a lot of these bacteria, you will be left with the survivors, and you will select these organisms out. And it's known in literature. We've done audits on it. Audits throughout in GGC would give you a 30% increase in Stenotrophomonas post-carbapenem use. We've looked at this patient cohort through a root cause analysis, and we've found that 60% of Stenotrophomonas in this cohort have had prior carbapenems. So it's well recognized and is actually occurring.
Well, if we can move to Stenotrophomonas, Stenotrophomonas isn't an enteric organism, is it?
No.
So it has to come from somewhere.
Yes.
And it's a question not where does it come from?
It will come from aquatic sources. And when you use carbapenems, the area it gets, you find colonization isn't the gut, it's the oropharynx. So it makes sense that you've ingested water with Stenotrophomonas within it. They reside in your oropharynx. And when you use the carbapenem, you will get selection and increased growth of those organisms within your oropharynx.
So just give me that again. Stenotrophomonas is not enteric, therefore a source is ingested water. Now it's the relationship. Have I got the antibiotic noted correctly? That's carbapenem.
Absolutely, a carbapenem is a class description, and that would it would encompass a number of specific agents in that. Meropenem is one of them and the most used one. There are others, but carbapenem is like describing it like a penicillin. But all of them, that class has got the ability, because of their broad spectrum of activity, of creating that selective pressure. And the importance of that is that carbapenems are really the antibiotics of were the antibiotics of last resort. There's newer agents in the market, but there was concern that we were seeing a lot of resistance developing in that agent or those agents.
Now, think which I did not follow was the what you would regard as the selective impact of carbapenem a prescription in relation to
Stenotrophomonas.
trophomonas.
So Stenotrophomonas are inherently resistant to carbapenems.
Right.
So they've done nothing clever. They just are. And so as soon as you give that agent, Stenotrophomonas is capable of surviving.
Right. Okay, I've got that. Thank you.
So can I just go back again to the question? I want to ask you about meropenem in a minute. But if Stenotrophomonas is not enteric, it must enter the, and somebody has suffered from that. It must enter the patient via some route, and I think you said water. Is that right?
Mm-hmm.
So the source of the infection remains water.
Ingested water, yes. But what we don't know is what duration, what period, what duration we can carry Stenotrophomonas.
In paragraph 192 of your witness statement, where you're dealing with Stenotrophomonas, if we can go back to that, you talk about a GGC review of cases. Yeah, sorry. Paragraph 192, page 112. And you see that? You talk about a GGC
Yeah.
review of cases. Is that something the inquiry has?
I'm not sure. I don't think so. This was a review done by Pamela Unidas on 99 cases, and it's a root cause analysis, is what it's titled. But the striking thing from that is that 2/3 of Stenotrophomonas cases had prior carbapenem up to 119 days prior. The duration of the agent prior, I don't think is important. We know that antibiotic resistance will be extant in somebody's body up to a year after an agent is given. And we know it's up to a year only because the trial guillotined or stopped after that period of time. So it is possible that we carry these antibiotic resistance organisms within ourselves for long durations of time.
Where were these cases, do you know? In one particular ward or one particular hospital or generally?
It was in the RHC QE, as far as I'm aware. I don't know the breakdown in terms of wards, but that data's available if required.
Well, I think I didn't know where it was.
Yeah.
That may be my fault because no one's given me it, but it may simply be that we haven't got it.
It may be.
No doubt those listening from the CLO will take steps to find out where it is, and if we haven't got it, to provide it to us at another stage, so we can actually have a look at it, because it's not entirely satisfactory to discuss it in the abstract without it being present, as you can appreciate. With meropenem, in effect, you're saying that one of the factors for somebody getting an illness is the prescription of meropenem.
With a specific organism, yes. Actually, could I they still have risk factors. The risk factors for translocation, it's not, I wouldn't want to give the impression that if you take meropenem, or I take meropenem, I'm going to come down with a Stenotrophomonas bacteremia. That's not the case. The risk factors for the bacteremia still exist within the patient cohort because of their immune suppression and the treatment that they are being put under. It's just that meropenem is the opportunistic pathogen that takes advantage of that scenario as a result of being selected out through...
Not meropenem. Meropenem's antibiotic.
Thank you very much. Stenotrophomonas takes the opportunity of causing the infection as a result of either current or previous meropenem use.
Yeah. So you're still looking to prevent Stenotrophomonas entering the systems of these individuals?
If you can, I mean, Stenotrophomonas is ubiquitous in the environment. It will, if you were to test domestic water, you will find it. So you have that paradoxical situation where we live in an environment where organisms are abundant everywhere, and yet we have to try our best to ensure that the health where we treat these patients are as safe as possible. There is still, we can only control one side of, or one part, a certain area in terms of infection potential once they're outside that area. And when I mean that, I mean the hospital and specialist areas in that hospital, then they would be susceptible to any environmental organism that they may encounter.
But while they're in the hospital, you're seeking to prevent them encountering it?
Absolutely.
Just before I forget about it, in 191, at the end of that paragraph, you said there could be issues of central venous catheter care. Do you have any evidence for criticizing the central venous catheter care when you make that statement?
No, it was a general statement. I know that there was a very excellent piece of work led by one of the senior nurses in pediatric hospital looking at central line bloodstream infections. They set themselves a very challenging target, best in class. They achieved it, and it was just, as a quality improvement piece of work, it was fantastic and was recognised. And it was only to suggest that we should be looking at every aspect of care and improving it as best we can. And I thought that was a good example. I'm not suggesting that that's the case, it's just an example.
Can we just move on to page 113? And I'm possibly just picking up a few bits and pieces in some of these cases, because with your proposition that one of the factors in people becoming ill is antibiotic use, we've got a little diverted. I mean, I suppose I just put that to you. I don't think anyone else has suggested to this inquiry that a factor in the issues encountered in the new hospital can be explained by reference to antibiotic use.
I'll take this as a safe space. I would take this as if there was an IMT. I would make that suggestion if it was an IMT. I would suggest it as a hypothesis, and I would like that hypothesis to be tested.
Okay, going on to 113 just for a minute, and then because we'll start to lose track of where we were in the chronological sequence. What the section under hypothesis is dealing with is, I think, a hypothesis of infections found and discussed at an IMT in relation to 6A. And I think you say here, one of the two hypotheses was exposure to unfiltered water out with Ward 6A. And I think the point that at places where there were not point of use filters is probably the point there. Is that correct?
Yes, sorry, yes.
So, and what you go on to say is efforts were made to see if it was possible to ensure that when patients who were otherwise in 6A had to go elsewhere, that pathway was covered by point of use filters, if at all possible.
That's correct.
That's what you understood was done.
Yes.
But you were surmising that the exposure to unfiltered water did seem to make sense in 197.
It does make sense.
So the likely cause of, or a possible cause, and I don't want to get into a debate about the correct use of likely or possible with you, but a possible cause of the infections seen at that time was unfiltered water, which happened to have been encountered not through a point of use filter.
That's possible.
And you said that seemed to make sense.
It does.
So that infection wasn't endogenous, that was due to exposure to unfiltered water, or seemed to be.
You don't know
sense.
that for certain.
No.
You're trying to mitigate as many risks as possible. It's already been identified as a risk in other areas, and so it makes perfect sense to ensure that that risk is removed because it's part of your hypothesis wherever it possibly can be.
Now, I'm not going to ask you about biofilms, because I'm going to ask you about that later. We'll touch on biofilms a little later on. And I know you say you're not an expert in biofilms, so it won't be a very long session, but we'll pick it up later on. It's just that you mentioned it in some of the succeeding paragraphs here. I'm moving now to page 122 of your witness statement, just really to get clear what we're saying here. We're dealing with the section under the heading microbiology report. And another organism has made its appearance, Delphtia acidovorans. And you say, I'm asked with inquiry why it's an unusual organism, and you say it's unusual to see it cause a clinical infection. So this was an oddity again.
Indeed.
Okay, bear with me a second. No, I'm going to move on. I'm going to ask you another question about biofilm, but I'll ask you them all in one batch. And you weren't an expert in chill beams, so I'm not going to ask you about chill beams.
Thank you.
You'll be very pleased to know. So we can move on. Can I then go to this is I'm not quite sure how this fits in the sequence, so I'll just ask you it generally. One of the criticisms that Dr. Peters had was that communications from IMTs to the clinical microbiologists was not good at all. And when you and Professor Jones were involved, you weren't really discussing the hypotheses with the clinical microbiology teams, although they were people who might have to do, for instance, out of hours cover. Now, do you recognize that criticism?
Not really, no. I would say that the communication, so it depends what level of detail is required to ensure that you can do your job safely. Out of hours, you are performing what I would call reactive infection control. You are not involved in longer pieces of work which have got possibly many moving parts, some of which may be fruitful and some of them may not be. So until you have certainty, you're exploring all avenues. I would say that there was enough information to ensure that a microbiologist could operate effectively between the hours of 5 o'clock and 9 o'clock the next morning if there was any issues that came up within that clinical area, and that would be reactive infection control. By that I mean immediate infection control actions that have to be taken to either ensure patient safety, staff safety, etc. So where do you put the patient? What should you do? And that is what is required to be done in an out of hours situation.
I think the criticism, it's assuming it is a criticism, is probably that here you had a very experienced microbiologist in Dr. Peters with a lot of experience in infection control, and she seems to think that when you and Professor Jones were involved, you really weren't discussing with her what was going on and bringing her up to date.
I don't recognise that as a issue. I don't recognise that myself and Professor Jones had a role to play in the IMT. We had that job to do where it was important that people knew what was happening. I think we would have communicated that to a level of detail that was required to ensure that patient safety wasn't compromised.
Well, that may be quite a nuanced distinction. I want to make sure I understand it. So it's a question of communicating the information someone needs so that they can do the cover that they may be asked to do, as opposed to engaging in a discussion about what the issues are, what the hypotheses are, and what's going on.
Correct.
These are two different things.
Indeed.
And you would say you did the latter, but not the former. I've got that right.
No, I think it was the other way around.
The other way around.
Mhm.
Yes, you provided the information, but didn't have the discussion.
Because if that was the case, if we had to do that, there's 19 microbiologists within GGC. We would potentially have to have that conversation 19 times.
Let's move on. 128, please. You'd be pleased to know I'm not about to ask you a lot of technical questions about HEPA filters, because we've confirmed your position on ventilation, and what you say here is, well, they might do some good, don't know whether they disrupt airflow or not, and they cause a bit of noise, but you think they might be helpful.
Yeah, I see them as win-wins. They're cheap. I don't know how effective they are. A lot more information came out during COVID about how they could or couldn't be used. They're effectively scrubbers. But I don't think there's nothing dangerous about them.
So better than not having them,
Agreed.
but presumably not as good as HEPA filtering the air before it enters the patient space.
Absolutely agreed.
Thank you. Now, I think we're possibly starting to head to a point where we can get your little clarification into the narrative, because in paragraph 272, which is on the same page, we start to identify some areas where you had a difference with Annette Rankin, who I think at that time was with difference of views. I'm not suggesting you had a stand-up argument. I'm simply...
Yeah, maybe. I mean, I've used the Net Rankin's name. I haven't got a difference of opinion with the Net Rankin. Net Rankin was there as the representative of HPS as it was at the time. And I think that was where the difference of views lay.
Yeah, I mean, you appear to have attributed, at least to her, the statement that we were looking at unique organisms, and you say, no, we weren't.
Yeah, and indeed.
Did you understand that clinicians thought these were either unique or certainly highly unusual that you were looking at the time? And did you agree with that view?
From a clinician point of view, yes. But from a microbiologist point of view, we know these organisms are there. When you do look backs, as we have a 10-year look back over these organisms from GGC, we will find we know these organisms are there in small numbers, handfuls, 1s, 2s, 3s, gaps of years, but the A to Z of the environmental organisms have been there. As microbiologists, we know about them. The tricky thing for us is understanding what they are. They're unusual to us insofar as their taxonomy changes, and you always know you've got an unusual organism when you have to Google it, because and then you find out it used to be called something else, which you understand as. So yes, I would think that my level of clinical knowledge is different from the clinician's, and a clinician's level of microbiological knowledge is different from my own.
I think I can understand why that might. So could I just maybe backtrack and see, tease that out a little? The proposition was put to you that clinicians seem to have recognized unusual infections. Now, as a layman, I don't necessarily immediately understand what that might mean, but it indicates that the clinicians do not come across them commonly. Now, were you saying that the experience of a microbiologist might be different?
Yes, because we will see these organisms coming from across every specialty and across a number of hospitals. The clinician will see these organisms as they relate to that particular specialty and that particular patient group. So they didn't have that breadth of vision that we would have. They, for instance, in hospital Y or another hospital in the GGC estate, we will see a unusual organism 1 year, and they've got no knowledge of it, but we do. We test over 1 million samples in any 1 year, and out of those 1 million, we will see some of these organisms coming through, not necessarily on the same place.
And where the data, as it were, that's available to both the clinicians and the microbiologists is blood sampling. Is that right? Or is it?
That's the easiest one to look at, yes.
Well, I'm just wondering if the clinicians on one hand and the microbiologists are looking at the same data sets.
Well, no, they're not, because the clinicians wouldn't have the ability or the interest in interrogating GGC's data set for these environmental organisms. They would be more interested in the organisms that they would see, which would be a subset and a small fraction of that. And so that would be the difference. We would, just because your denominator is so much smaller, you wouldn't see these organisms quite so frequently, if at all, in this patient group, whereas across the whole 5 acute hospitals in GGC, we would.
But, and I again apologize for my pedestrian approach, we are talking about blood samples as opposed to environmental samples.
Yes, yes.
Yes. But I do see that clinicians in a particular area will be interested in their particular patients. Right, thank you.
So it's entirely possible, if I follow this narrative through, that clinicians dealing with, say, pediatric hemo-oncology, because that's obviously one of the main areas we've been looking at, might say, well, we've never seen this before in our experience. And I think we know that a number of the clinicians have very extensive experience in that area, and combined, they probably have a huge amount of experience. And you wouldn't necessarily say that they've got that wrong. It's just that somewhere else, at some other point in some other ward or some other hospital, someone may have encountered the same thing.
Correct.
Yeah. Right. Let me move on to another label for you. Pseudo outbreak.
Ah.
You knew I was going to ask you about
Yeah,
that, didn't you? Because you've headed it off, as it were, in your witness statement. And I'm going to take it backwards in terms of how you've set it out. A pseudo outbreak, and you correct me if I'm wrong because you're the expert and I'm not. A pseudo outbreak, properly understood, the standard usage of that term is where there has been some contamination from some external source in the lab or in the handling or something like that. So in fact, what you think you're doing is looking at an outbreak, but it's nothing to do with that. It's somewhere in the processing system the infection has entered.
Correct.
So that's a pseudo outbreak, because somebody at the end result gets results which suggest a problem, but in fact it's contamination in between. Yeah. Now, you, I think, came under some challenge, at least, for using the phrase pseudo outbreak in the context of IMT discussions. And as I understand it, what you set out in your witness statement now is you didn't actually mean a pseudo outbreak in its standard form at all. You meant something different.
So I used the term quite deliberately, really to try and captivate or engage the clinicians in an opinion that I had, that I felt that the outbreak definition was very broad, thus making it not specific. By I mean not specific, I mean in the sense that you will get false positives. And so infections that arise will be attributed to an outbreak when they are not. And thus you're in the potential situation of having an unending perpetual outbreak, because what you're actually describing is the natural infective epidemiology within this patient cohort. And I deliberately used that to try and see if we could engender a discussion within the IMT such that we could tease that out as a concept. I'm not sure it actually happened. I think I'm
just a bit puzzled by it, because if somebody knew the meaning of pseudo outbreak as meaning a situation that isn't an infection in the patient at all, it's come through some contaminated route, why would you deliberately use that phrase in discussion, knowing it was not correct?
Because I didn't know that there was any other way I could actually describe what my opinion was without using something akin to that terminology. And I didn't use it, a pseudo outbreak, in isolation. I gave the contextualization that the outbreak definition was so broad that we were in danger of perpetuating an outbreak because of a non-specific outbreak definition that was capturing all.
This is perhaps where we better get to the correction that you wanted to make to your statement. That as I understand it, what you were saying in your statement was you were criticising the use of all gram negatives as a group that were being adopted, but you don't think on reflection that phraseology is what you intended to use. Is that right?
That's right. That was a transfer from a previous version of my statement. So I understand the then as now it was organisms from water and soil that were associated with 6A or pathways within that. So that was my error. What I would say is, like, mentally, we are talking about gram negatives because that's the group of organisms that these environmental organisms are, plus the enterics are gram negatives as well. So it was a effective shorthand, mental shorthand.
Is there a particular passage in the statement you would wish to take me to, Mr. Connell, so I could reflect that correction?
Yes, Lord.
If I can help, I think
Please
it's
do, yeah.
paragraph 233, 278, and 325.
Right. If you just give me this again, 233.
233, 278, and 325.
Okay.
Your Lordship.
But let's just go to page 129 first of all, please, because that's where we get 278, and then if it starts at the foot where you say you use the term with its normal usage, and then on 130, this is where you pick up this point. Is that right?
Yes.
And instead of all gram negatives, I'm not quite sure where you say that directly, but what you accept is that.
I mean, that expression is found at the very bottom of page 129. Yeah.
No one was actually saying all gram negatives. It was gram negatives associated with soil and water.
Yeah, that's correct.
So what you were objecting to was people looking for gram-negative infections associated with soil and water as a group, as opposed to any particular one or more of these.
No, what I was trying to highlight was that the enteric organisms Klebsiella and Enterobacter were by default being put into an environmental basket and not into an enteric basket, or they were being analysed both within environmental and enteric, but not enteric and gram negatives. So there was no differentiation between any of those organisms in terms of their source, either endogenous or exogenous. They were all assumed to be exogenous.
Although in two cases, they can also be endogenous.
Of course, but there was never any differentiation, as I could see, whereby they tried to, the IMT tried to work out where the actual ultimate source was. And it was assumed in every instance that it was exogenous, even though these are endogenous organisms.
But they can also be exogenous.
And they can also be exogenous.
Yes. So if I get this, if I can strip that down, your objection was that by including in a collection of gram-negative organisms associated with soil and water, two organisms which could also be found in the patient's body naturally occurring, that was causing a problem.
Sorry, causing a problem within the patient, or causing
Well,
a problem
no.
to me, or causing a problem to the data?
Causing a problem to the process that you were undertaking at the time.
I don't know it would cause a problem. It's just an observation that I felt that there wasn't enough stringency in highlighting or trying to delineate where those two organisms, Klebsiella and Enterobacter, were coming from. And they were always assumed to be coming from out with the patient. And we know that's not the case.
Was that not what you were trying to establish, where they were coming from? Because the point of the IMT, if you go back to the discussion we had earlier today, if you're not looking to exclude the hospital as the source, if you go back to the old approach, which is try and find out what the problem is and how to fix it, you're trying to find out where organisms of concern may be coming from.
Yes, but I don't think that process occurred. The assumption was they were always environmental.
And were you assuming they weren't?
I wasn't assuming anything. All I was saying is that it was the assumption throughout the IMT was that they were all environmental.
It's part of the history we've got of what happened in the new hospital is of people making investigations, trying to work out where something's coming from and possibly intervening in some way. Let's just say, to oversimplify it, somebody suggested it might be the drinking water, right? No more drinking water from the taps, let's have bottled water. And the infections then go down. Now, and then they recur for some other reason, but just sticking at that point, if they go down after an intervention of that kind, then the initial hypothesis seems at least to be tenable.
It would be tenable. It might not be right.
If they were getting the infection not from the water, but from some other means, you would need to be able to work out what that alternative was.
Correct.
Because that's one of the debates that you probably be aware has circulated, that it's all very well saying, oh, it wasn't the environment, but you have to show where another route for the infection to happen.
And you do try, and you're not always successful. I have been in IMTs over my career where you do not get to the source of a proven source of where the infection came from. And ultimately, the infection goes away. The issue, you've put in a number of mitigations, you don't know which ones worked. Everyone's very thankful that the problem's gone, but if you were to actually point to one mitigation or one source, you might not be able to say that's what done it. And that's just the nature of trying to deal with infections in complex systems. And this was a very complex, long drawn out investigative process. And I'm afraid that's just what happens sometimes.
Well, thank you for making the point that you don't always find the source, because that's one that a number of people have made. Do you get any indications as to what the source might be by the success of the interventions you make?
If they were done one by one, in terms of a natural experiment, you could, but that's not the nature of an IMT. You do every mitigate, you prioritize your hypotheses, you look at how you're going to investigate them, how you're going to potentially mitigate them, you put all the mitigations in place as fast and as efficiently as you can, and then you watch and wait. Or you refine your hypothesis from new information that comes through. So you don't have that ability to do an actual experiment and wait and see for an effect. For instance, an effect may be months down the line if we're talking about water systems. Let's say, for instance, you thought that chlorine dioxide was the key mitigation that you needed. It would take months. The engineers will tell you it can now take 2 years to clear a system. You can't wait that long. This all has to be done the very next day. So in theory, yes, but in practice, I don't know how you would be able to do that. And that's why in some cases, you never know what the source is, because you can't then say the mitigation at that point affected that source, because it all happened quickly. Yeah. And even if, when you come down to it, I said the situation is multifactorial. Even within that, there's smaller subsets within the large Venn diagram of the infection that if somebody's practice isn't great, that will affect what the potential source is. So by that I mean that you still need a chain of transmission, a link between what you think the potential source is and how that potential pathogen or that organism gets into the patient's body.
Yeah. So your point quite properly is you can't say, well, let's not bother stopping them drinking the water. We'll do something else, but we won't do that. And if they still get ill, then we'll know it might be the drinking water, because you can't take that risk with the patient.
Absolutely.
On the other hand, if all of the steps you took were focused on excluding potential routes for non-filtered water being encountered by the patient, and the infection stopped, you might think reasonably that had been the source.
If that was your only mitigation, but it won't be your only mitigation. The other mitigations would be look at practice. You would look at antibiotic prophylaxis. You would look at potential I was getting mechanical devices, for instance, catheter hubs, line care, etc. So there'll be a number of things that you'll look at. But if you're right, if you did one thing and one thing only, you would be able to identify that source. But that's a very, very high risk strategy, because if it's not that source, you have unwittingly allowed infections to continue.
Can we just pick up before we break another of the references that we want to make sure we've corrected? I think it's in paragraph 325, which appears on 140. Have I got the number right?
Yes, that's correct.
So where you say at the start of that paragraph, Annette Rankin is absolutely right. Her definition of the outbreak was all gram-negatives. It wasn't actually.
It wasn't, no. And that's, I can only apologise to the inquiry.
Sure. I might just ask you a slightly different question before we finish. Could we have, no, don't bring it up at the moment. One of the issues that has arisen for discussion is whether one has or should have background rates of particular organisms. Some people taking the view you should be aiming not to have background rates, others taking a different view. At an earlier stage, a table was produced by Dr. Kennedy with a whole range of organisms. And I wonder if we could just look at this. It's bundle 6, page 121. Now, there's a great long list of organisms. You may or may not be able to help us. Can you tell us, though, whether, in your view, any or all of these should have a background rate, as it's been described?
I don't think I can be specific, because a background rate would be the rate of infections that you would see in a patient population as a result of their potential risk factors, rather than because of the organism themselves. The risk factors in the patient are the things that will dictate whether they're susceptible to infections or not. We live in an environment of organisms. The back of your hand, every square centimetre will have 100,000 organisms on it. That's the level. I could swab this desk and there will be organisms on it. Your keyboard that people are using, we know there's organisms on it. We live in that environment. So it's a risk profile of the patient rather than the organisms themselves. Now, the difference with these organisms are they're usually recognized as low pathogenic potential. The reason for that is they have been selectively driven towards having a gene set that will allow them to survive in a low nutrient environment and might not necessarily have the genes that they require to infect an immunocompetent person. But an immunocompromised person, I believe, is potentially capable of being infected by any organism by nature of their risk.
Thank you. We'll just leave that. I'll ask two further questions, if I may, and with His Lordship's permission, I'll just do that now. Apparently, you prepared something called an environmental sampling policy in 2020, and Dr. Peters was asked to give feedback on it. First of all, do you recall doing that?
No. Is this a infection control SOP?
I assume so.
Okay.
The point is simply that it has been suggested that you prepared the policy. She didn't think it was fit for purpose and gave you that feedback. Do you recall that at all?
No, I don't.
And just one about behaviours, if I may, straying a little bit from the kind of topics we've been discussing this morning. After the Scottish Government were involved in matters at the board, we've had some evidence that a psychologist appeared on the scene, somebody called Jenny Copeland. Do you remember her?
Yes.
And there was somebody called Angela Wallace also involved.
Yes.
And the suggestion is that there were things called buzz meetings at which both of these would be present.
Yes.
As well as Dr. Peters. Now, the suggestion is that you tended to laugh every time Dr. Peters spoke and had to be stopped for both doing that and speaking over her. Do you have any recollection of that?
I have a recollection of once I forgot myself on a Teams meeting in a back bedroom, and I would say it was more of a wry smile. To say it was a laugh was an embellishment, and I didn't deliberately talk over Dr. Peters, but sometimes it's difficult in a Teams meeting to know when somebody has stopped talking, and I may have inadvertently come in too soon.
Thank you. I think that might be an appropriate point, Leanord.
Yes, we'll take our lunch break now, Professor, and if you could be back for 2 o'clock. Thank you.
Please stand.